So the first topic would be on artificial intelligence in healthcare and diabetes by Dr. Amit Kumar De.
Audio is not there. So thank you very much, Dr. Shanmugan and everybody in the organizing committee. Thank you for inviting us, and thank you for organizing this workshop on artificial intelligence. I guess whoever is interested can come forward. We can make it more interactive, more discussion. Let's get to learn from each other as well. It's an evolving segment, and it's always encouraging to see doctors interested about learning this technology, understanding this technology. So I think I will just quickly introduce what we are going to do. I think we have a 1.5 hour session. If I'm not 1 hour session, we have a 1 hour session. So I will start by giving you a very basic understanding of what artificial intelligence is and how this is coming in the field of healthcare and how healthcare is going to change. And then followed by my colleagues, Dr. S.V. Kulkarni sir, Harsh, and we are all going to collaboratively give you some examples with the ethical application. We'll talk about will AI replace clinicians or not, and some hands-on understanding of how we can start using, okay? So just to introduce about myself, I'm Dr. Amit Kumar De. I'm the founder chair of the Doctors AI community. We are a global community having more than 3,500, 4,000 doctors connected to us on social platforms. And we also have the Indian College of Artificial Intelligence in Medicine, which is a college. It's an organization which helps clinicians learn, adopt, and understand this technology of artificial intelligence. So we will talk about where and how to start with understanding some of the basics of artificial intelligence. A quick disclosure from all of us, including the other people in the panelist, that we will be talking about maybe some proprietorship model throughout the presentation, but we don't mean to endorse them. And a lot of AI has gone in preparing these presentations. If you're all having your mobile phones, we'll request all of you to kindly keep it in your hand so you can get some quick QR codes and get yourselves engaged and get started with artificial intelligence even after this 1 hour of session. So 3 segments I'm going to cover. The first is let's quickly understand what is artificial intelligence and how this intersection comes in the segment of medicine, because we speak about evidence-based medicine. Intelligence comes in an algorithmic way, in a structured computational way. So let us understand some technical definitions which can overlap with our medical definitions as we understand. So this is one of the oldest definitions of artificial intelligence, which means the ability of an ecosystem to understand, learn, reason, and make decisions to solve problems. And this is, if you look at it, this is a very old definition published in 1977, so this whole technology is not new. It's been there for many years, and it is evolving every single day as we speak, and today we have generative AI, which is a fantastic evolution that takes us forward. So if I have to just explain what AI will mean in the field of healthcare, is that artificial intelligence will be that segment that is going to be mimicking just the way our human mind is trained to think. So think about as an undergraduate, a postgraduate student, or a faculty associate professor in a medical college to a senior clinician, we have our own algorithmic way of thinking certain things. So let's take, for example, if I give you a number called 7, then there is no value. That's a data, right? If I tell you that the hemoglobin of a person is 7, then I'm giving you an information. This is exactly the way our mind also processes it. Now when I give you a history saying that there is a person in the emergency department who has come following a road traffic accident and his hemoglobin is 7, which means I'm adding some knowledge to that data, or I'm adding some knowledge to that information. Now what we have learned from our medical learning, if a person comes to the emergency department with a hemoglobin of 7 following an RTA, what is the wisest thing to do? Give blood transfusion, and that is wisdom. So this is how our mind acts, and this is exactly how we are also training AI to act. And this is how the entire ecosystem of human and artificial intelligence, the human intelligence and artificial intelligence together is going to come. That's why we actually call it augmented intelligence and not artificial intelligence. Giving you an overview of the field of healthcare, you will find AI coming in personalized treatment, virtual health assistants, in advanced diagnostics with predictive analytics. Now, we will show you in this 1 hour, small snippets how you can start using it, but the real game of using AI is in predictive analytics. So if you can have algorithms that can actually tell you whether to treat or not, guide you, not tell you, and not instruct you, but guide you whether to treat or not, whom to treat in a more precise way based on multiple parameters. That's why we see the potential of clinical decision-making capability of a clinician changing with the support of algorithm. While I speak on this, I would like to reiterate and tell you all the way we have been also trained to think is in an algorithmic way. We do our flow chart of going from a differential diagnosis to a provisional diagnosis, and if you can train a computer ecosystem to do that, it will follow the same levels of thought process, and it is going to give you a very assisted answer in doing that. Drug discovery is getting augmented. I'll tell you about this. Treatment optimization with more and more personalized assistance. Optimizing surgery, this is where there'll be an overlap of robotics coming in, augmented reality, virtual reality coming in, and telemedicine will also get augmented with the help of remote AI monitoring. Where do we stand? We stand somewhere between artificial narrow intelligence and artificial general intelligence. So we're still not in that phase of machine intelligence yet, but with the newer models, GPT-5 and everything coming in, we're gradually shifting into agentic artificial intelligence, which is kind of taking us into the segment of machine intelligence. So this is where we stand, and we may reach a stage of machine consciousness where we will have an intellect that is much smarter than the best human brains in practically every field. So as I said in the very beginning that this is a domain which is not very new, and it has been evolving since many years, since the time Alan Turing coined the term Turing test, and John McCarthy actually was the first person to coin the term artificial intelligence. There has been development of machine learning, deep learning. Machine learning and deep learning is the conventional AI that has been there, and a larger segment of healthcare AI research is with machine learning and deep learning algorithms. In 2022, generative AI came into existence by OpenAI, Sam Altman and team, and there became a huge hype that this is probably a technology that can be also useful in the field of healthcare, and hence we are talking about it. So here you are the tools that you're using. Knowingly or unknowingly, we are all using AI in our daily life. Your virtual assistants, social media is full of AI. It has got a lot of algorithms going in there. Language translators, navigation system, these are also some forms of artificial intelligence following an algorithmic instruction. How do you see AI coming in medicine or diabetes, whatever you say, through wearables, deep learning algorithms, robotic process automations, virtual assistants, and chatbots going forward. As we speak, a lot of AI tools are coming in. Regulated, unregulated, semi-regulated, we do not know, but there's a huge ecosystem of development happening across the globe, mostly in the Middle East and in the US, but also the Indian bootstrap market is picking up. This is a 2023 list, a busy slide, tells you about all the FDA-approved AI tools, and since then there's also been many, many more tools which have been developed over the years, and this list is counting, and it's going to be ever-growing. Now, in the next 3 to 4 minutes, let me also quickly give you a quick understanding of some of the basic terminologies of artificial intelligence. So as I said, the whole subset is artificial intelligence, which means it mimics the intelligence or behavior pattern of humans or any other living entity. So just the way an undergraduate and a postgraduate is taught in clinics how to think of in a clinical case, you can teach an algorithm how to think on that line and behave like a clinical decision support system. If it is learning from the data, so in technology world, there is data, there is strings and numbers. If it's learning from the data and gives you a pattern and understanding of the pattern, that is called machine learning. When this learning is happening with the help of neural networks, which again mimics the neural network of our brain, that is called deep learning, right? So these are the different three primary segments of artificial intelligence. To simplify, a subset of AI is machine learning, a subset of machine learning is deep learning, and a subset of deep learning is where your generative AI, your GPT, Perplexity, your WhatsApp Meta on your WhatsApp phone, all these are existing. So basically it's a shift from case-driven expert reasoning to machine learning, which is data-driven. And this is why this is data-driven. That's why it is going to be very, very useful towards taking us towards intelligence-based medicine or precision medicine, as we call it. Machine learning is basically playing with numbers and data. There are three types: supervised, unsupervised, reinforcement learning. I tell this in a very simplified way for people who are hearing it for the first time. Supervised learning is basically a postgraduate trainee who's got a good guide, teaches him, trains him, tells him 2 plus 2 is 4, and he learns that 2 plus 2 is 4. Unsupervised learning is that intern in the medical college who keeps on shifting on different departments, hopping and jumping, and gets to learn on his own through his own experience. So there is a black box possibility, there is a possibility that some things may not be explained as to why it is giving. Both has its plus, both has its minus. We have to use it wisely. Reinforcement learning is basically learning by mistakes. This is again a human nature. We all learn from mistakes, from our own mistakes, and this is again a way in which we are trying to train AI to also do that. Deep neural networks is basically the neural networks, the way it works in our brain. So you have the nodes, the internodes, the weights. The way our synapses are connected, you can have an artificial neural network work in the same way. Which means if you train it with an image of a dog, it will predict that it's a dog. You train it with an image of a cat, it will predict it's a cat. How can we use this in the field of healthcare? It will be having multiple layers, pre-processing, feature extraction, and modeling, and eventually an output is going to come in. So if you can train it with the image of an X-ray, which tells about pulmonary COX, and if it has been well trained, then it will classify that it is positive or it is negative for tuberculosis, right? So this is where the neural network, artificial neural network comes in the field of healthcare. What is generative AI? The ability to create content, create text, audio, video, anything from an instruction which I'm giving. Now, it is important to give an instruction to the AI ecosystem. Why are we all using AI? Because we can talk to it, we can chat to it. We are not coders, we are not vibe coders, but we can still communicate with it. And the process by which we are able to communicate with it is called NLP, or natural language processing. So generative AI is the science. Large language models are the models which are following this science, and the way in which we are interacting with the ecosystem is with the help of NLP, or natural language processing. So you give the data in the form of text, image, speech, structured data. It undergoes training iteration through multiple layers of deep neural network. This is what happens in the back end. This is also called a foundation model or transformer model. And then you get the output. But the output that you get is not in the form of codes. Computer only understands binary, right? 0 and 1. But the output it is giving you is also in your language. So you're talking to it in your language, but it is also giving the response back to your own language, like your chat GPT, like your Perplexity. And then you have your GPT becomes one of your friend. And how is this possible? This is possible with the help of this powerful technology which overlaps with AI called NLP, or natural language processing. And this makes it so user friendly that we are all able to interact with the artificial intelligence ecosystem. When you have to interact with this NLP ecosystem, you have to give it an instruction. And the better instruction you give, the better output you will give. Sometimes we say this is a flawed AI system, or this is an unintelligent AI system. Well, it's not that. The more intelligent prompt we give or instruction we give, the better output is going to be expected from that AI ecosystem. So this art of giving the right instruction is called prompting. It's a science, it's called prompt engineering. And however, you need to learn the art of prompting, and that is very, very important, which takes into consideration language, communication, creativity, critical thinking, subject matter expertise, and everything. Prompting techniques are there. Try to understand the purpose, keep it clear, use a priming prompt, give it an example, and keep on playing and toggling with the different kind of prompts to get different kind of response coming forward. Again, as I say, it's a science. There is prompt engineering. There are different types of prompts that can be learned. There are courses to teach you on this. In fact, we also conduct courses in our organization. But more importantly, it's an art. Doctors need to know the art of communication skill. I think we need to learn the art of interacting with the AI ecosystem as well. Get yourself started with artificial intelligence. This is important for every clinician. So this is where your QR code comes out. You can scan, and this is the first textbook of AI in medicine written by some of our colleagues, Dr. Shambo, Dr. Bharat, myself. And we came up with this textbook. It's a very thin textbook, so it gets you started with AI. It's available with the JP publishers. You can just get a copy of it online, order it from them, and you can get started with this understanding of this technology at the intersection of medicine. The last segment, in the next 2 or 3 minutes, why and where does a clinician get to start with artificial intelligence? You know, I've been doing AI for the last, I guess, 5 to 7 years in a full blow, and even before that with some companies. Every time a question gets asked to me is that where do I get started? I'm a busy clinician, I see 70 consults in a day, or I'm an avid researcher, but where do I get started? So there has to be a structured way in which every clinician needs to get started. Not only clinician, undergraduate, postgraduates, faculties. So everybody will have their own tiers of learning. Before I get into where, let me answer quickly 5 questions why, and this is important. You know, Jeffrey Hinton is a person who says that I think we are moving into a period when for the first time we may have things which are more intelligent than us. And this is exactly the reason why we need to tame this technology to make the best use of it, otherwise the technology will start taming us. Eric Topol, a fantastic researcher and academician based out of US, had a chance to interact with him a couple of times, says that patient wants to be more autonomous than they're not so dependent. And we have the tools to do that. We talk about patient centricity, precision medicine. AI can actually help us do that. So why artificial intelligence? The 5 reasons: it will help us elevate our performance beyond the standards of care. So in all our researches, we talk about standards of care. It will take us to personalized care, right? Drug discovery will come down. Drug discovery will get augmented. I'll take a couple of more minutes and then adjust with the final time. Drug discovery will come down, and the timeline will get shortened. What this will do is that the entire ecosystem of the cost that goes behind developing a drug will come down. Think on that in terms of healthcare equity. One of the major reasons of why is this. You know, throughout the last 2 days, all of you have been engaged in a diabetes conference. And what have you been talking about? Just the tip of the iceberg. RCTs, clinical case studies, some meta-analysis, some systematic reviews. What we have been missing is the data point which can tell us bigger stories about the patient, from the patient side. And this is a thing which needs to be picked up from AI. This shift is happening very fast. This information and knowledge gap is happening very fast, and we need to keep pace with it. And trust me, it's very difficult to keep pace with it, even if you're doing it regularly. Last reason is, of course, the cognitive bias. You know, our mind is trained to see what our eyes think about what our eyes commonly see, and that takes us to a cognitive bias. And this can be overcome as a neutralizing factor when you have an AI assistant connecting with you. So the final point is, from evidence-based medicine, we need to move to that segment of precision medicine or intelligence-based medicine. And AI can be the right juncture tool to help us get into that. How will this happen? Multiple entry points are going to be there. This is the entire ecosystem, from screening to treatment and management, and all this will get collected in the big cloud, and it will help us understand the data and make some meaningful outcome out of it. And now you know how this happens. So you give the input, it analyzes, and you finally get an output coming out in the form of classification, prediction, generation, control, etc. So AI will help us transition from evidence-based medicine into data-driven clinical medicine. And for this, we need to understand the technology. This is not a Star Trek movie or a fascinating gizmo. There is a science behind it, there is an algorithm behind it, and we need to ask the question, how is this algorithm working, so that we can find evidence to use it regularly. The last part, of course, I will invite all of you to get connected with us at Doctors AI, so you can scan this QR code and be a part of the community. And I will invite all of you also. Yeah, I'll just give this QR code so you can all join the community, and it just gets you started. You know, as a clinician, we have a lot of discussions happening in the Doctors AI community. And at the end, I just want to leave you with the thoughts how you can get started. So first is, strategize the learning experience. Okay, we are all learners as clinicians, we are all learners from day one. So where do we get started with? Because it's important that we be bilingual. We need to understand the technology jargon a little bit as much as we understand the medical jargon. So get a foundation knowledge. So workshops like this or primers that we conduct are foundation knowledge. Try to find a need gap in your practice that can be solved with AI. Collaborate in finding out an application. Dr. Kulkarni sir will speak about the ethical and legal applications. As doctors, we have taken an oath to do no harm, and we must follow that and know this very carefully. But collaboration and communication is very, very important in this entire AI ecosystem. There will be 3 tiers of learning: basic, proficient, and expert. Most of us will have basic and proficient learning. Expert is for those like our friends Harsh, who can actually go into code and they can develop solutions with the help of the tech developers. So get familiar with primers, do workshops, certification programs. We also have something in our organization, and then if this really is food for you or it tickles your thought process, you can go for advanced training certification program. To end, artificial intelligence will help us see what we have been actually missing. And representing the International Diabetes Federation from the AI Technology Committee, we are now calling for responsible artificial intelligence, which means there has to be explainability, there has to be transparency, there has to be reasoning behind the AI tool. AI is not about making PowerPoint presentation or just creating a social media post. It's about having those predictive analytics that can make you a more intelligent physician. We have the Indian College of AI in Medicine, and if anybody is interested to become a member, you can scan this QR code and join us at the Indian College of AI in Medicine. We do a lot of activities throughout the year. Last, before I end, I would like to invite you all to join us in Bengaluru this year in November, where we are hosting the first of its kind clinician-driven AI summit, which is the Doctors AI Global Summit. We'll be having some fantastic international speakers coming in. This is happening on 15th and 16th of November. And there is some exciting sessions that will happen with multi-specialities, not only on diabetes care, but multi-specialities. And we'll have some host of international speakers joining in. So this is the QR code that you can scan to register for the conference and join us. At the end, I would like to just tell you all that, we have all taken the oath of doing no harm, the oath of trying to do our best as a clinician. But now I think it's also time that we evolve with that, and we must all look at understanding the data, because the data of the patient tells you a lot of story, and then let's try not do any harm to the patient. Thank you very much for your patient hearing, and I will now invite the next speaker. I think it's Dr. Shivakumar who's going to be speaking, and we will take up some questions again at the end and discussion. Dr. Shivakumar, please.
Thank you for the organizing team for providing this wonderful opportunity to move on to this next topic, that is how artificial intelligence helps to predict risk as well as reducing the risk, and that's how it sets the stage for precision medicine. So of course, my disclaimer, I have used my artificial intelligence tool to prepare this particular topic. And here now, rightly Dr. Amit Dey pointed out, and of course he is very much senior to me. I am in this segment for just 3-4 years in artificial intelligence. But even before that, I was thinking how this data, the so-called raw data, which we were using, in a way what we were using, like say for example, we have our own intuition where we think about our patients with our experience, and with that framework we see the subsequent patients to predict all those things. The story goes like this. In 80s, we had a professor of medicine in Madurai Medical College, where he was a chronic smoker. So when he got severe abdominal pain, he told that, see, this is due to obstruction in the splenic artery. Like that he told. At that point of time, we don't have much advanced technologies like CT or ultrasound, which was in very primitive stage, So nobody, other consultants, they didn't agree, but when they opened, they found there is thrombus in the splenic artery. So that was the way intuition of human mind works, and that's how artificial intelligence also going to work. But what is the difference between how this human intelligence and artificial intelligence going to co-work or so-called co-piloting? So because this is what the decision making helps us to predict or prevent the disease or give better decisions. Say for example, we had the session on yoga where we were thinking about our mind, and our mind acts in a different way, Our habits and personality, all these things form a framework, and this makes us to see like what we see. Say for example, what the mind doesn't know, the eyes cannot see. This is what we learn. And in the same way, if we don't understand the technologies properly, whatever the data we have, it's not going to be helpful for our day-to-day clinical practice. Of course, Dr. Amit Dey set a clear stage for that. And the problem is not just population-based. We know we have a lot of guidelines, and guidelines are signposts. This is what Dr. V. Mohan used to say. Guidelines say everything about how to deal with, say for example, clinical approach, then starting with some therapy, whether it is anti-diabetic or anti-hypertensive or hyperlipidemia, whatever it may be, like that. There are certain clear-cut guidelines. And apart from guidelines, we have our own set of experience, because 1 out of 10 patients in type 2 diabetes practice, they don't tolerate metformin at all, but metformin forms the baseline. This is what the guideline says. Of course, we had that disclaimer there itself. Unless otherwise there are no contraindication, metformin forms the drug of choice, the first choice in addressing A1C less than 7.5. So this is how the guidelines are framed using randomized clinical trials. Then what is the difference between these randomized clinical trials and real world evidences? Real world evidences is what we tend to generate in our day-to-day clinical practice, which were handwritten prescriptions, all those things. And all these handwritten prescriptions, handwritten data points like whatever history taking, clinical examination findings, everything was paper based. When it becomes computerized, we have huge data, and that data, when we make it as a real world evidence, and from that data we can form the whatever the things, like, because we can think big pictures, like say for example general medicine is a place where we can see the human as a whole, unlike the subspecialties like cardiologists see only the heart, nephrologists see only the brain, all those things. But how this artificial intelligence is going to help? So this can analyze huge number of data in a fraction of a second and give an idea or summary, whatever in the form you require. Like most of you will be using ChatGPT or Perplexity, whatever it may be the tool, where you can summarize everything. And here some of you might have observed, still it is not flawless. Of course, it's going to mature soon, because two or 3 years ago when it was launched, it was very immature. Now it's getting much more mature. And of course, we know even in the countries like US, where everything is systematic, everything is EMR based, still the drug mismatch happens, and there are a lot of deaths happening due to malprescription. So all these things can be addressed with the help of technology. And of course, what we call as co-pilot, that is, the pilot starts everything, sets the stage, then the flight starts, it taxi on, then it rises, and once it reaches the sky, the co-pilot, that is the system that takes over. And this is how even in future, that is, right now we have, and in future we are going to have all these things, like lot of data, the EHR lab imaging, all those genomics and wearable data, this is going to be integrated soon, and this is not too far away. All these things will help, and these data in a busy clinical practice like what we see in every day 40 or 50 patients, it is hard to analyze. So all this analysis can be done with the help of AI tools and technology, and that's how it's going to help to improve our clinical acumen, as well as whatever we miss, like early signals of kidney decline, all those things. Because see, last year the patient might have come with EGFR of 90 or 95. Now the EGFR might be 85. Next year it will be 75. We cannot see all those things in busy clinical practice, but AI tools can do all this graphically, and it can predict when he is going to land up in chronic kidney disease or end-stage kidney disease. So to summarize this thing, AI just simplifies our clinical abilities, much like in the initial days, ECG machines amplified our ability to hear the heart. So we know, see, with the help of, while we were students, we were doing all the ECG analysis manually, then in the machine itself, we get everything like PR interval, QRS duration, QT interval, all those things. Like this, AI tools are going to help us to interpret each and everything. Only thing is, we need to be much more intelligent enough to analyze all these things. Of course, we are. So these are all some of the evidences where even RCTs themselves move towards precision medicine. So the so-called precision medicine is nothing but, again in good old student days, I was asking my teachers, sir, in Davidson metronidazole dose is written as 800 milligram 3 times in a day, but in prescription you are giving 400 milligram or 200 milligram 3 times in a day. How they see you are not following whatever there in the textbook. So at that point of time he was explaining, see, the people living in UK, there are well built, minimum weight will be 70 kg like that, here 35 or 40 kg. As a students we don't know. But in the same way, see, we are all continuous learners, We don't know with a huge number of populations how these things happen. And always we have certain frameworks like, இந்த patient இப்படி தான் இருக்கும். That kind of things is not going to work in future. So all these intuitive things will be complemented with the help of AI, with the help of data, and even RCTs are moving towards that. And of course, we are able to predict certain things like diabetes remission and functional improvement in walking distance for peripheral arterial disease and liver disease resolution, all those things through the trials in themselves. And certain things like this is what dynamic personalization, this is what continuous machine learning. So we know machine learning, it learns the data by itself. And one more thing, it is not just 1 plus 1 is equal to 2 in medicine. Again, this is what the teaching is, that is correct, because that's why we framed the probabilistic model. Like a patient who is presenting to us with chest pain, positive predictive value of 90% when he has all those things, radiations, then TROP positive, all those things, like that. That is the probabilistic model. So that all this probabilistic model can be analyzed with the massive data with the help of AI technology, and we know we have dynamic personalization. Say for example, again in clinical practice, we might miss the patient would be diabetic with coronary artery disease, with LDL cholesterol of 90, still we will be happy. That is our intuition. But EMR can point out, see, LDL target is 55 for extreme risk patient. So that's how it is going to change the way we think. We are biased, and that bias correction is going to happen in future. Of course, we see single BP at every visit, and we can visualize as a chart when he has more than 50% of the time all these blood pressure recordings more than 180, then we can decide fast enough to address all this blood pressure reduction in a better way with better available drugs. So this is how it is going to individualize the patient needs and predict the risk as well as prevent the complications. And like this, we can combine all the things available like type 2 diabetes with chronic kidney disease. We might have missed the EGFR data. It can come and prompt the EGFR is just 60. If you give vildagliptin once daily, that may be sufficient, or sitagliptin 50 milligram, that may be sufficient, like that. So ultimately, AI is not going to replace clinical wisdom, but it augments. And again, it is rightly pointed out by Dr. Amit Dey. And this is what my final few slides. The future of care is like this: identify high-risk patients before complications develop. Say, for example, nowadays, when a person joins to some job, he undergoes some master checkup. So he has that particular data at the age of 20 or 21. Then subsequently, when he changes the job again, he is going to undergo the complete master checkup. If you match the data points, different data points at different timelines, now you can predict when this particular person is going to develop diabetes or not, with the background family history of diabetes or not, hypertension, hyperlipidemia, and there might be background history of early myocardial infarction in the family, and that may come as a prompt, and that will help to decide. Even though LDL is just 103 and TGL is 177, this particular person needs high intensity statin therapy. All these things are possible with the help of predictive technology, and of course in that way we can prevent the occurrence of disease itself, or at least we can prevent the complications that is going to happen in futures, and particularly the personalization. So the precision medicine is about a group of people having similar profile, like what we have clusters of diabetes in our practice. Unlike it is type 1 and diabetes, now we have clusters in diabetes, which is about precision medicine. With the help of C-peptide levels, all those things, we classify the patients in different categories of cluster. Like that is precision medicine. But in personalization medicine, it is the individual person we are treating. See, the person, even though we say once we diagnose type 2 diabetes, it is cardiac risk equivalent. Again, this is discussed in our various forums. It is not exactly the same cardiovascular risk at 5 years or 7 years later. So somebody will have more risk and few people might have lesser risk. All those things can be analyzed with the help of data with artificial intelligence. And of course, this is going to be a big partner in our future like a co-pilot. I will stop here. So, thank you for your kind attention.
Thank you for setting up the stage for a very good topic in day-to-day intervention of diabetes management. What I am going to talk is about what are the ethical, practical issues of using AI in diabetes. I have got a disclaimer, I have not used AI in preparing these slides, and these slides are more practical than what you get either on Google or Perplexity or your other LLMs like ChatGPT. Full screen. So my thanks to the organizers, Diabetic Association of India, South Southern Chapter, and who has helped me to. So friends, this is me. I am the Dean of Indian College of Artificial Intelligence in Medicine. This is my 43rd year of medical practice, and I believe in very practical management of patients with the help of newer technologies. I bring you greetings from this alumni of my medical college, MGM Medical College, Panvel. So this is the brief flow of diabetes care. Whenever you are seeing a patient of diabetes, you have got a huge amount of data. Then the data can be multimodal. It can be text, it can be image, it can be a CT scan, it can be a laboratory report. Then how you can utilize it for the best of the patient and how it will save your time and it will give a best possible diagnosis and management which suits to the theme of the today's conference. So I'm going to show you first 3 slides, which is the abstract of my talk. The ethical issues are data privacy and informed consent. The second problem which we face is bias and inclusivity. And the third is the transparency and explainability. We will go one by one. The second situation is the legal issues, in which you have got liability and accountability. Everybody asks me a simple question. Suppose if you use an AI model and if you treat somebody with the answer which you get from him, and if something goes wrong, who is responsible? It is the person who is using AI, the physician who is using AI is responsible. There are a lot of regulatory oversights, and there is a problem related to cross-border data flow. Means you cannot transfer Indian data to US or UK for analysis and other things. These are the very important practical things. We face in India something very difficult, infrastructure and interoperability. Amit is keeping his record in Helpflix, I am keeping in Doc1, somebody is keeping on some other formulation. So if you want to integrate the data, it is not possible. It is called as interoperability. Second point is affordability. Are we in a position to afford all the LLMs which are available in the market? There are many people who will still prefer to use the free versions which are available. It is my request for all of you that if you can buy a paid version, it will be more proficient, it will give fantastic outputs. And the third point is the digital literacy. What this workshop we are having, what all other activities are happening in the digital scenario of the country, they are very important steps for make the doctors, but at the same time we must make our paramedical staff also digitally literate. So what is the purpose of human intelligence? I don't call it as AI as an artificial intelligence, it is augmented intelligence. It makes our job easy. It is the benefits which are there for all the AI era, which should reach to all the practitioners, all the patients. So you apply the principles of accessibility, availability, affordability and adaptability. Tomorrow morning, you should be in a position to use something what you have learned in this hour. So the first part is ethics. So what are the ethical issues? I just told you about data privacy, informed consent, bias and inclusivity, transparency and explainability. Let us go into one. These are the watershed areas. They all fuse together. There is no rigid definition of principles, motives and final utility. And everywhere, whenever you are doing, there is not a single generative AI model which is 100% accurate. Please take it for. There is not a single model which is, and it is the ethics which lie between the 2 ears of the physician. Whatever LLMs you use, whatever the applications you use, you have to use your own brain, and this is a full spectrum. This is a full ethical spectrum of all the ethical things what we do. It starts from governance, value alignment, accountability. It should be human centered. It should be reliable. There should be privacy security. It should avoid unfair bias, and there should be social well-being. But what are the main 4 pillars? Number 1 is beneficence. It should bring benefit. It should bring benefit. Then it should not do any harm. It should have autonomy, and it should have justice. That means it should ensure fairness. So these are the basic principles: beneficence, autonomy and justice. Most important is explainability. We must be in a position to tell our patients or our research subjects that in what way we are using their data. This explainability should be in very simple language. The next point is called as fairness. Are we fair to everything while using any LLMs? So that will help to avoid bias and favors. And what are the 2 main points in between? There is something called as the black box phenomena, and there is a second concept called as hallucinations, where the AI outrightly gives you a wrong answer or a confusing answer. So looking positively, what you should look into any model which you are using, that it should be robust, it should be transparent, and it should maintain the privacy. The best question out of everything is the ownership. Who owns the data? Ultimately, it is the patient who owns the data of his own health and all the health parameters. Coming to the second part of my talk, that is liability and accountability, regulatory oversights and cross-border data flow. Let us go into details of it, because these are the problems which you are likely to face not today. After 2 years, 3 years, 5 years, when the things are going to be used. So there are lot many regulatory gaps and which are liable for errors. There is a problem related to data protection and sovereignty. Intellectual Property Act. Suppose Amit develops some model and he wants to ask for its patent. Now on whose data the patent is based and how he can get an Intellectual Property Act. Then there is some concept called as a medical device regulation. Medical device as a treatment, an application as a treatment, a LLM as a treatment. And ethics of clinical trial and AI training is going to make a sea change in the future of the things. So these are some of the points which we will go into the details. What are the regulatory guidelines in India in the world? There are existing legal and policy foundations. There is an act called as the Digital Personal Data Protection Act, DP 2023. It is the cornerstone of the governance. And these are the key points of DP Act of 24. Data can only be processed by specified or legitimate purpose. Only necessary personal data can be collected. I give an example. I got a patient who is HBS positive and HIV positive. Am I going to include into his EHR? And if it is included into EHR, when his prescription goes out, can the pharmacist read it? I know that with the true conditions, whatever drugs I am going to give, those drugs are going to have a lot of interactions. So it is a complex interplay. So in my EHR, I should have a column that this data can be seen only by the consultant, and it will not be printed on the prescription paper. So you have to do a lot of reverse engineering. So data should be remained only for as long as it is required, and organizations must implement appropriate security measures. It is very important, and all the individuals have right to access, correct and erase the personal data as far as the right of data portability and right to object the processing. This looks a bit complex, but if it comes to some practical issue, it is going to be a big problem. Our another body is ICMR. ICMR has complemented the ethical guidelines of applications of AI. It respects patient autonomy, safety, and algorithm transparency. These guidelines mandate human oversight in clinical decisions involving AI and require develops a validated AI tool through rigorous testing. This word is very important, rigorous testing. And this is the reference. You go to ICMR and you will find all the things. What are the main points which you again have to have in ethical principles? Autonomy and human agency. The patient's autonomy is the most important thing. Now, there is this we talked about India. What about the whole world? There is a EU Act, but our Indian Act lacks binding regulations specifically targeting high-risk AI applications in healthcare. Please don't be right. And the absence of centralized regulatory body for AI in medical devices, it creates a problem. Soon, I think, Amit, we are going to have this body, and people are asking for suggestions. So, as a AI user, as a physician, it is your duty to inform the government and the stakeholders that what the things which they want. There is an international law. What is that? GDPR, General Data Protection Regulation Act. Again, it has got the subject right, the Design and Default Act, the Data Breach Note, Accountability, Purpose Limitation, and Data Security. These are all the very important. Now, coming to my last point of discussion is the practical issue. We discussed about infrastructure, interoperability, affordability, and digital literacy. What should we face is low digital literacy can be managed by training of our staff. It is only a single point training. They don't need to know all the basics of AI tools. The health access inequality can be avoided by ABDM. The cultural sensitivity has to be respected, and again, this is the biggest cancer of the country, that is corruption and oversight. We should try to help. And what is the end? The safety and risk mitigation. Whenever you are using any AI tool, any digital technology, the safety and risk mitigation should be done. There are a lot of impacts on the businesses. There are a lot of complex obligations, data breach notification, cross-border data transfers, and there are a lot of significant data fiduciaries may be required to appoint as a data protection officer. So, after few years, in every hospital, there will be a data protection officer who will be lead. So, just to summarize, the organization should appoint an officer to protect the data, implement policies and procedures, train employees, monitor, clarify and review the practices, and non-compliance can lead to a lot of significant points. So, the legal policy and collaborative measures, strengthening the data privacy and security, establish liability and accountability frameworks, and professional association involvement. This is one of the best steps that RSSDA or any diabetes association is involved in making this concept of imbibing use of AI technology in diabetes management. The previous speaker talked about precision medicine. This is the same way. It is a precision and protective medicine for all the diabetic patients. So in conclusion, we should adopt a balanced approach, developing comprehensive AI regulation, ensure your ethical AI design, strengthening data protection laws. We should promote inclusivity, and we should partner with healthcare providers, AI developers, because engineers don't know what doctors want, and doctors also don't know what engineers have. So we have to partner with them so that picks up your fifth P in the and if you want to know more about things, these are the references, these are the WHO guides. My presentation is available for all of you. There is one very good book that is a very good read for all of us. There are many questions. So friends, what I feel, why you should use AI? Like good manufacturing processes, we should have good artificial intelligence practices in practice. So all of us, we should have a dream. What should be a dream? A dream of a blind can read aloud. A laryngectomy person can speak clearly, cleverly. The plagia word is abolished from medical dictionary by using brain-computer interface and the exoskeletons. All the NCDs, non-communicable disease, are diagnosed at or before birth, giving a fair prevention window, and all the data is ethically safe and secure. So with this note, I welcome you to the Future of Medicine with our organization called as the Doctors AI. These are the links which Dr. Amit has already shared, but those who have not taken a screenshot or scanned the QR code, this is our group called as the Doctors AI. We are a very strong community of 3,000 plus people. Then we regularly conduct a certificate course on artificial intelligence. It is one of the first type of the course in the country. I will say it can be on a global also, because the US courses cost you in lakhs of rupees. There are Indian courses which you cost around 60,000-70,000 rupees, but you can always compare and know the things. And if you want to know more, join us on 15th and 16th November in Bengaluru, so that we can know more about all finer aspects of diabetes management using artificial intelligence in clinical practice, and it will make a change doctor. The question asked is only one thing: is AI going to replace doctors? No. But it will replace the doctors who are not using AI. So be on a protective side of the fence, and it raises your level of serum enthusiasm. Take it from me. I am 70. I started practicing digital technology and AI from 2002, when it was all the things were in infancy. But it makes you really very comfortable, right from a first year student to a vice chancellor or to a minister also. Thank you very much. Young generation takes over. So we have got generations of AI enthusiasts in our country. So Harsh represents the, I think, not third Harsh, even fourth generation. Yeah. If you consider that there are one generation is 10 years, then Harsh is fourth generation AI enthusiast in our group. Thank you. I appreciate all your presence here, and your questions and your comments are very important and valuable for us, because this is the only way in which we can, make ourselves more comfortable in managing further things.
All right, so before I begin, can I request everyone to answer me one question? What is that one common thing between sensory motor cortex area 1, supplementary area, and your prefrontal cortex? What's that one thing which is common in all the three? Any idea? All three are, activated centers for learning? Yes? Any doubt in that? Acha, I'll give you one more take. There's one more thing which is common in them. All three of them get activated with clapping. All three of them. So can I request a huge round of applause to the speakers who spoke before me for setting the foundation right, and to the entire DAISICON committee, Dr. Vijay sir, Dr. Balaji, Dr. Shanmugan sir, for organizing this amazing event and hosting us in this beautiful venue and city. So I have no disclosures for this entire presentation, except for a few which are our proprietary patented solutions which are developed by our company. I represent a company which is called Doc Yantra Private Limited. It started with me and my two co-founders, Dr. Bharat Sabu and Dr. Alok Modi, and Shift Foundation, which is India's largest healthcare technology foundation. We just launched it formally a month back, and more we'll discuss later. So coming to the topic which has been given to me, these are the tools which have been used to build this presentation, but the context and the content is citation and reference tagged in this entire presentation. Only the visual aspect of this presentation have been developed using AI. So yes, the DAISICON, now I'm going to request all to please give a clap. Yes, to the entire committee. So the question, what was beautifully raised by speakers before me is, will future AI replace doctors in diabetes care? Well, what do you think? How many of you think it will replace? Give me an honest raise of hands. No one? Perfect. So now we are on the same page. So next 10 minutes, oh, you feel it's going to replace? Not 100%? But AI assisted. Superb, superb. Nice. So this sets the stage for next 10 to 12 minutes, which I'm going to quickly run on what's happening and what's coming. Yes. So now the hype, as we see, is AI outperforms doctors. Yes. But let me tell you the reality. 0 physicians across the globe have been replaced by AI. This is a data from Stanford and many other organizations across the globe. No doctors at any point have been replaced. There was an attempt made in China to replace a doctor with an automated AI clinic, which miserably failed. So they have withdrawn the project. So stay rest assured. India's diabetes crisis, I don't need to iterate this, we've been listening this over the last 2 days. Close to 100 plus million people are developing and are in the window of diabetes. So here AI is not a threat to our profession, but it can be a force multiplier to bridge the widening care gap. So if we look at what AI excels at, AI is something which excels in rapid pattern recognition in massive data sets. How we learned from Dr. Amit that, there are certain aspects of prediction, there are certain newer aspects of data interpretation which AI can give. So rapid pattern recognition, prediction, automation of routine labor-consuming tasks which can be taken care by AI. The physician delivers the trust, empathy, cultural nuance, and most importantly, the wisdom of experience. What Dr. Kulkarni said, he's been in the field for more than 3 decades. So that wisdom is what AI cannot replace. So, summarizing, the future isn't the choice between human and machine, but it's a powerful synergy. And that, again, leads to a mandate, which is AI manages your data, but we manage the patient. So this is the world we are entering into. This is the future we are entering into. So let me dive you into the future. Are we ready for it? Yes? All of you? Yes. Even the last row? Yes. Perfect. So now, let's look at key common applications of AI in diabetes care. We have already seen predictive analysis, pattern recognition, but AID has taken a major spike in last 2 years. Automated insulin delivery systems have truly changed the way insulin pumps have been working. A lot of AI there. Personalized recommendations have also been there. The most important aspect to understand is in your actual practical practice, how is AI going to integrate you is on your workflow. So a traditional workflow is manual data entry, time-intensive process. You need an assistant to keep a physical record of things. Experience-based decisions you have to make constantly. Retrospective pattern analysis you cannot do. You cannot do a prospective pattern analysis. Patient engagement, which is on a periodic person-to-person basis. AI-enhanced workflow, right? This is what is your future. Automated documentation, more time per patient, actual doctor to patient interaction time. What's the biggest complaints patients have in 21st century, especially in 2025? Doctor ko time nahi hai. Why? Because of these labor intensive process. The moment you can automate the processes in your patient care, which does not require your medical intelligence, but it requires your mechanical intelligence, you're going to have more time to spend with your patient to actually interact and know and talk to the patient. Evidence-based recommendations, predictive pattern recognition, continuous remote monitoring and virtual assistant and coaching. So this is what AI can offer you in your day-to-day practice. So let's imagine ourselves meeting again in the same hall in 2030, 5 years down the line. What is a possibility? Kya ho sakta hai? What's the possibility we can anticipate? What could be a future? In your 2030, there may come a time where morning mein AI has quickly reviewed AI flagged high-risk patients in your IEP, and AI suggests interventions which is waiting for your final judgment. The data sets, the data sheets are ready. You just need to approve it, modify it, or put your wisdom to see whether it has done it well or not. That's your morning. When you reach your clinic from your rounds, an entire focus on patient connection. Talking to the patient, listening to the patient. The data offloading has already been done by AI for you. So history summary, potential issues have been flagged by AI, and complex cases when we're handling, leveraging AI for differential diagnosis, drug interactions, rapid evidence-based literature review. Earlier it used to take anywhere around 3 to 4 hours to do any review of AI-based, any review of paper or anything we're doing. Now AI does it in a matter of minutes. And that too from critical resources. As Dr. Kulkarni sir said, AI does hallucinate a lot. But now we have some solutions which have come up recently over the last 2 to 3 months where the citation referencing is also dead accurate. So that's the shift we are seeing now. Coming to the kind of takeaway on this entire future, what we are imagining of 2030 is a more meaningful time with patients, a reduced administrative burden, and most importantly, enhanced clinical decision-making ability. So this is where we are heading. One another future intervention, what is happening very rapidly as we speak right now is AI integration in CGM. How this is changing is 280 plus, so current CGMs have ability to record 250 plus readings across 24 hours, which summarizes to close to 2,000 readings across 14 days. plus rate of change of sugar fluctuations across 24 hours, pattern variations and trend variations. This entire data offloading can also be done with AI, because human analysis versus AI, if we do, less than 1% of total data can be processed by human beings, but AI can do 100%, and that too day and night. So that's the AI transition. This is yet very interesting study which was published in Nature Digital just few months back, where they did a retrospective cohort study for a pre-diabetes patient, using CGM. The key differentiator was both were AI-based interventions. The pre-diabetic, which was more of the power user, more enthusiastic, because they wanted to prevent diabetes from coming in, the AI augmented outcomes from that CGM data, you can see how much weight loss they achieved. 4 pounds. Just due to AI augmentation. The lifestyle changes and other confounding factors are left aside. So that's the power, friends. Yet another exciting study, this was published in Frontiers of Endocrinology, again this year only, where CGM advantages when integrating with AI versus the regular CGM approaches, real-time data capturing with pattern recognition actually led to an early predictive outcome prediction of postprandial hypoglycemia. Any prandial, lunch prandial, dinner prandial, breakfast prandial, you take any meal, the predictive index was more accurate than a human prediction. So these are some amazing things happening. Emerging innovations, AI-driven drug discovery, digital twins, we are already seeing few in markets now, generative AI documentation, precision genomic profiling, enhanced clinical trials using AI, mental health chatbots, resource optimization using AI, and most importantly, in the space of orthopedics, we are seeing a tectonic shift in how the rehabilitation is happening with AI. So a lot of centers across the country have got robotic physiotherapy now, where AI integration has happened, leading to even a faster outcomes, an improvement in patient rehabilitation. So certain other technologies which are emerging as we speak right now, the future, Moglu, it's one of the technology which got CES Award of 2025 this year, which is one of the world's largest tech expo. So this is based on Raman spectroscopy. It's a non-invasive glucose monitoring. It has been cleared by EU and entering an FDA regulatory committee in next few weeks. We have GlucoWare, again a non-invasive product. This is in fact one of the first, there have been 10 or 12 different watches which have come as non-invasive glucose meters, but this is the first one which has cleared 2 certifications, and it's in further development as we speak. GlucoTrack is yet another project from Israel, which is having a ultrasonic, electromagnetic and thermal technology integration. So 3 types of sensors are integrating data, and AI is augmenting all the 3 data and giving an outcome. This is the device. And conversation AI models which we are developing in our technology unit, which are again voice activated. There's a better accessibility. We have integrated 18 different Indian languages into our bots, and we have increased its functionality to a larger space. And yes, as Dr. Kulkarni sir said, privacy is very, very important. So we have actually got a lawyer who has done an AI-based technology law to help us guide the DBDB constraints around the solutions what we're building. So now we saw what's happening, what's coming, right? I'm going to showcase you what's there already. So future of, AI revolution is not coming, it's already here. And I'm going to show you some of our original research work, what we did over last 6 to 8 months in my organization. And starting with one of the first, which we published right here in Chennai, 1 month back. We won the best research abstract of 2025, where we compared 3 existing AI chatbots in medical query answering. So imagine yourselves as 3 students giving a USMLE exam. We threw 500 questions of medical science at each of the bots and did a comparative outcome on how they were responding to it. So this was the study we published. We also did a data security audit. I repeat, audit of these bots on medical information. And the outcomes are very surprising. We took the 3 AI models which are freely accessible. Only 2 models could cross the 80% benchmark, rather 85% benchmark to be safe in any diagnostic prediction, such as X-ray prediction, differential diagnosis and all. Medical exams, the exams what we took, only 2 passed. 85% is the minimum mandate for an AI tool. Drug safety, only one AI tool passed at 94% when it comes to drug interaction, the reliability of output what you get from AI. So it is very, very important to understand AI is there, but it is still developing. Yes, more and more needs to be worked around it. Text processing, the research speed also we measured on each of the tools. So one of the tools, Gemini 3, we saw it has 42 pages reading ability in one single minute. So that's the magnitude. So the second paper we published was when IJCDEM, where we looked at a solution, we built a solution called Paper Crafter, which basically drafts a framework for writing a research project. Let's say you have 1,000 patients, you want to look into, say, retrospective analysis for urinary microalbuminuria. You have data, but you don't have time to create the framework of it. Now, this does not write a paper for you, friends. A paper likh ke nahi dega. And even if it writes, the journal will reject it. What this does is, it creates a framework for your research plan, right? This publication we did in February, and we published it. The third one we worked on was something called, what Dr. K. Shivakumar was mentioning, the predictive analysis of risk outcomes. So diabetes risk factors. So we created a solution and did a validation study for the solution, which we published, where this solution, this paper, actually we could see high assessment accuracy metrics of 4.6 to 5 scoring. So we had multiple doctors physically use this and validate from a side-by-side manual report analysis. So the scoring was 4.6 to 5, and the phenotype relevance. See, most of the AI tools right now are West biased. They are on Western data.
Sir, it's time.
Yeah, sure. I started at 8:55, which was, my time was 8:45. So if there's a permission, I can take 2 or 3 more minutes. Yeah. Okay. So, So I was mentioning on the accuracy part of the solution. So that's where, so most of the tools, what we see in current, are trained on Western data. This was on Asian Indian phenotype. So that really changes the whole paradigm. The third tool what we published our research was with IJDT, International Journal of Diabetes Technology, where we worked on CGM Mestro. So we worked on a tool which processes CGM data into actionable outcomes on therapeutics. And this therapeutics was trained on Katzeng's textbook of pharmacology. So the AI was actually made to learn from it and create an outcome-based data based on PKPD metrics. So this was the research we did. This got us best abstract at DTech this year. It is based on situational learning, this entire paper, what we published. The outcome was very interesting of our research. We had 20 healthcare practitioners, we had 10 physicians, we had 5 endocrinologists, and we had 5 other specialty doctors who handle diabetes. And 70% of clinicians anticipated a 25% improvement in patient outcomes with the tool's full deployment. So this was done at a prototype stage. Currently we are at phase 3 of the development of this research solution. And the one which really changed our this year's trajectory was what we published at ADA this year. Dr. Bharat Sabu got Best Early Career Abstract Award of 2025 for this year, which has been the first Indian to receive this award. Can we give a huge round of applause for this? And this we got for, I was privileged to be part of this project with Dr. Alok Modi as well. And we did a validation of world's first indigenic patient interaction bot of diabetes education. We included Marathi, we included Tamil, we had Telugu, we had more than 25 languages which were trained on this, and that got us this award for this year. And so looking at the final few slides of where we are headed to, okay, perfect. So we have done some more other research work. We have done some footfall analysis tools in your clinic. A lot of these we have done. We have done a medico-legal education. And the last concluding part for my session before I hand over to the team is, the challenges are there, as we rightly saw in the ethics part. But the future is here. Our patients need our wisdom, which is enhanced by analysis. They need our compassion supported by AI's efficiency. The irreplaceable human element is empathy, intuition, and human touch, because one of my patients actually said this to my team, that AI solutions do give our numbers, but the doctor said that I would be able to see my granddaughter's wedding. Now this magic is what we as clinicians have. AI is only there to give us data. Thank you all for your patient listening. We would love to welcome you all to join this healthcare technology revolution. You can take a snapshot and join. We are doing a 12-week masterclass series online from 12th September. We would love you all to join there and be part of this. We have 8,000 plus doctors from 18 specialties joining this and taking forward. Thank you once again and welcoming everyone to 2026 DAISICON as well. Thank you all. Thank you.
So any comments or any questions? I think it's been a very brainstorming sessions by each of the speakers, and we did a very comprehensive coverage of the entire spectrum. Professor Kulkarni, please join us. Of understanding the basics of artificial intelligence, getting yourself a little familiar with some of the terms, and then we understood about the ethics and the applications, about using it in a responsible way, in a transparent way. Dr. Shivakumar and Dr. Harsh beautifully demonstrated some of the practical applications and how it can change the way we are practicing medicine and bring in precision medicine. And I think Harsh also beautifully showed some of the work that they have done and how precision work can actually be improved with the help of AI insights coming in. So any comments and thoughts, anything from the house?
If you don't have any comments, I will suggest you to take a part in one project where your voice modulation, your 5-minute speech to a patient who is not ready for insulin treatment. So how you can convince, you imagine that there is a patient sitting in front of you with HbA1c of 10.5, he is young, he has got a very high fasting and PP blood sugar with all dyslipidemia, and you are convincing him. So it is your voice modulation, how your voice gives empathy, or sometimes you cannot say, "Tumko lene ka hai to lene to jao." There are some doctors who can even talk like that. So how it can help you? This is one project which is going on, and this is just one offshoot of it. The basic of research is either you ask a question, second you raise a hypothesis, or third is the refute a hypothesis. Whatever I said that you should have a data protection officer, it is not possible. It is not possible for a small hospital. So there has to be central agency which you can do like this. So you please think out of the box. That is the most important thing. What we are trying to do all over the country is to ignite the passion and to know more and more things of the practical aspects which can be done in a different way. Harsh, can you tell about that food pressure study?
So, as sir beautifully said, there's an exciting study which has happened, which is on food pressure analysis, where the pressure points of different food for any diabetes person can actually predict the ulcer development or risk of developing ulcer in that zone, and to a level where now, when they've integrated thermal imaging with it, so earlier it was only pressure imaging, now they've integrated thermal imaging in it, they are even predicting the avascularization. That level of prediction we have achieved. Imagine the kind of lives we can save it, the kind of amputations which can be prevented with this. So as sir rightly said, there are some very exciting solutions and studies which are happening right now in our entire space, and this is good to be future ready now, because that's going to enhance our care to patients in future. Yes?
So Dr. Shivakumar, I have a question for you, and you are a physician entrepreneur, and you are developing a solution, a clinical decision support system, and to some of our friends here, just to make you understand what a clinical decision support system is, it's going to be an assisted technology which is going to pull in information not only from the textbook but also from the prevalent guidelines and also from the practicing trends, from your local regional practicing trends, and that's where the concept, I think, of federated learning will also come in, Dr. Shivakumar, and it will be able to give you recommendations into your practice. But when a CDSS comes in, especially in the field at this moment we are in the intersection of using agentic solutions, agentic AI solutions. So it is going to be very important that we draw a fine line between how much you want to automate and what you should automate, right? So these tools needs to be evaluated and validated in a proper way before they are put and deployed into clinical practice, because it holds the potential of motivating a clinician to make different clinical judgments if they would have not used it otherwise. So as a physician and as an entrepreneur building solutions, how do you propose that these evaluations and validations are done? And for example, your organization also, your company is also using it. So what methods are you using of involving more clinicians into validating these tools?
Yeah, actually, thank you for putting forward this particular interesting area where, because we talk about these clinical decision support systems for quite a long time, But it's not that we don't have clinical decision support systems. The era where Dr. Kulkarni was started practicing with the technology in 2002, I started using technology from 2004. So I bought my first computer to have my digital health record, because at that point of time that was the need. Like the diabetic patients fail to bring their prescriptions, we don't know how much insulin we have given, what kind of drugs we have given. That was the pain point at that time. So the decision support system is very simple. It is like 5 different stages of automation in car. Like say for example, no automation at all in the car. It's like they're driving very much manually. Now we have so many ADAS system, you might have heard in your car. And Tesla, that is the highest ADAS system they are using. That is automated. So many things are automated. We have cameras, we have all those things like that. Like that in clinical decision support system, the Harvard classification is 5 different stages. So when everything is physical, then there is no automation. When you simply give digital prescription, which is going to be very much passive, it is the level 1, like driving a car with very little automation, and then sending reminders and getting some automatic calculations like body mass index, because if you put the data height and weight, automatic calculation of BMI, then automatic calculation of EGFR, all those things. This is level 2 like that. And third level will be like integrating this guidelines into your day-to-day clinical practice through the technology. And like that it goes on. The highest level of clinical decision support system is, it's like augmented intelligence, what we are discussing. So in that level, it can help a lot. It acts as a co-pilot, where one thing is, even though it is a co-pilot, just like in Tesla car, there is always disclaimer. Just like in ChatGPT, we get that disclaimer. AI can do mistakes, beware about that. Like that, we have to put the disclaimer that is for the ethical as well as safety, security purposes. And in that way, at some point of time, we don't know exactly, like 2035, we are going to achieve the so-called singularity, all those things. We don't know. That time might come sooner or later. It is highly impossible. But for all practical things, what we can do is we can create our own data. Because, India is a place where many people throughout the globe, like Gulf countries, Singapore, Malaysia, even from there come here and get treated, they get the benefit. Why? It is all like we have better empathy than other country. We have better systems, better intuitions, but we don't have data adequately. But if we have data adequately, if we do modeling, we will be the topmost in the globe. Thank you.
Yeah, so yes, please.
One common and practical question. At this point, we all accept that AI is really useful for doctors, and AI-assisted treatment is on the way. Everyone has a fear, every doctor has a fear that other than surgical specialty, procedure-based specialty, they think in another 10 years, this AI will replace all of us, starting from radiology, dermatology, diabetology, everyone having the fear. AI will completely replace, and AI and patient without doctor. This is, every doctor is fearing about this. You are practicing in a periphery, okay? And do you think the socio-economic, cultural factors and bonding, that relationship between other than treatment, all other things, in peripheries, this bonding, whether this AI is going to break all these barriers or not?
I clearly tell from my own story here. So, last month we had a patient, and he returned from Gulf country. He has come for treatment. So, I was suggesting him, his A1C was like 9.5 and so on, like that. He's a obese person. I was about to tell at that time, that is injectable semaglutide was not launched here. Only the tirzepatide was launched in Kumbakonam. So I was suggesting him, sir, you can have, you are having very good option of achieving remission through some available molecules. Odane he was asking, is it Mounjaro or Wegovy? See, the level of knowledge by the patient nowadays. இதே இது வந்து 25 years முன்னாடி பிஹெச்சியில் உட்கார்றப்போ இப்போ உனக்கு ரத்த கொதிப்பு இருக்குது அப்படின்னா சார் ரத்தமே இல்லை எப்படி சார் கொதிக்கும் அப்படின்னு கேட்குற பேஷண்ட் போய் இப்போ வந்து ஒரு தாத்தா இப்போ லாஸ்ட் வீக் வர்றாரு. ஹீ இஸ் கம்மிங் அண்ட் ஹீ இஸ் டெல்லிங் தட் சார் மை grandson told from ChatGPT that my LDL should be 70 and less than that. Now the LDL is 90. What should I do? Of course, this is open-ended question to me, isn't it? So if they ask like this, what is going to be our response? So we need to be updated. Are we really implementing in our clinical practice? The data, whatever comes through the output of this Gemini, ChatGPT, is very much precise, concise, and also understandable. It makes us understand. It makes the patient more understandable. But if you think positively, it is a very great tool for the patients to understand the disease itself in a better way. Like Dr. Kulkarni was saying, when we use the technology appropriately, and that is going to help. Just in 5 years ago, we had certain other difficulties. Like say for example, they will simply Google, they will come with misinformation, lot of misinformation. Now it's not like that. They are coming with clear-cut information. What should be my LDL target? That kind of question comes. A
person who searches on GPT will definitely get better results than when he searches on the normal algorithmic process of Google. And I just want to add one point before Dr. Kulkarni makes his comment, is that there's always a fine line between augmentation and automation. The more we automate, the more we pull ourselves into the trap of getting biased. That's called automation bias. With CDSs coming in, with agents coming in, with agentic AI solutions coming in, we will always have a drift of going into automation bias. This is where we have to, what I showed in the beginning, that we have to tame the technology rather than the technology trying to tame us. Otherwise you will have, you will be driven into that. So that this fine line will have to be defined by medical professionals in the dictum of medical science, just the way we have defined our oath this way, which is augmentation and what is automation, what should be done, what should be allowed and what should not be allowed. Of course, the law of the land will govern us, but the voice of the community, the medical community, will very be important in how we are, going into this change.
Yeah. Last comment. Combinations are always better. Shankar Jaikishan, Lakshmikant parallel, two can come together, and Shankar Ehsan Loy can give still better music. So you remember the triangle which he had shown. I give a keyword for all of you. It is called as a KABP. What is that? Does that mean? K is knowledge. A is attitude. In that attitude, you add AI, which will change your behavior, your clinical behavior, and the practices will change. The patient will be very much benefited with all the P's what he told, that right, you can prevent, protect and predict different complications. So this is the way in which it should be utilized, and I think that is the best answer for all these questions.
So I think, yes, I think our time is also up, and thank you very much everyone for being engaged in this discussion. Just one point of note to all of us is that this is where we are just getting started. So don't feel despair that there's a lot happening and you can't catch up and you can't follow. It's all about getting started with this. So once you're into this groove of getting started, there are 3 things that will tickle you. One is you need to constantly be curious to learn and understand this thing more, because it's not the conventional domain the way we are taught in medical school. Be a little adaptive to these changes that is happening. Don't shun it away just because you don't understand it. And always have a hunger for adopting to newer things coming in your way. I think that is what's going to put us in the mettle of being a better clinicians. Thank you so much. Thank you to all our panelists and faculties for joining.